Hello everyone. Our today's topic is the odontogenic infection. The odontogenic infection, they are the most common infection that affects the head and the neck. An infection that occurs when the harmful microorganisms they enter the oral cavity, causing harm to the host organisms, are termed as odontogenic infection. So Uh, most of these infections can be effectively managed with the minimum complications, including serious illness or even the death. Timely and appropriate treatment like the antibiotics and early extraction of the problematic tooth can significantly shorten the duration of infection and lower the risk of further complication. Now let us discuss the microbiology of the odontogenic infection. These infections usually involves the opportunistic pathogens that are found naturally in the mouth, that are the streptococci and anaerobic bacteria. They usually work together to cause these infections. Initially, initially you will see they are initially the aerobic streptococci they are more dominant, but over time the infection it becomes dominated by the anaerobic gram positive cocci and the negative rods. What are the common microorganisms that are most commonly seen? Uh, Common bacteria in the severe cases includes the Streptococcus, Staphylococcus, Lactobacillus, Prevotella, Treponema, Fusobacterium, Veillonella. These all are important for exam point of view. Now, what is the mechanism of enzyme that are produced by these microorganisms? These microorganisms they will produce enzyme like streptokinase. The streptokinase it's a enzyme that is produced by the certain bacteria. What is the main function of the streptokinase? Its function is to break down the fibrin. It is also known as fibronacin. It will break down the fibrin. That is a protein that is involved in the blood clotting formation. By breaking down the fibrin, the streptokinase would help to dissolve the blood clot, and that is why it will facilitate the movement of the bacteria within the body. So that will that will promote the spread of bacterial infection to the other areas. The second is the enzyme is the hyaluronidase. Now it is an enzyme that is produced by certain microorganisms. We know its role is to break down the hyaluronic acid that is found in the it is a connective substance that is found in the connective tissue. Now breaking down this hyaluronidase would weaken the structure of the connective tissue. It would weak down the connective tissue. That will allow the bacteria to move more easily through these tissues. That results in a rapid spread. The third is the streptodornase. Now, streptodornase it is an enzyme that break down DNA and RNA that is present in the cellular debris. By lysing the cellular debris, the streptodornase it will help to assist the breakdown of the dead cells and the tissue remnants that can contribute to the rapid spread of the bacterial invaders. These microorganisms they will produce enzymes like streptokinase, hyaluronidase, and streptodornase. So, uh, these enzymes collectively help the bacteria move more easily, break down the tissue barriers, and spread quickly within the body. That results in progression of the disease. Now, let us discuss the pathway of the odontogenic infection. All right, so when we talk about the odontogenic infection, we are referring to infection that originates from our mouth or the teeth. So these infection can become pretty serious, especially if they spread beyond the tooth socket. Now, one of the main ways these infections spread through is known as the pulpal infection. So this happens when the inner part of the tooth, that is the pulp, it get infected. So when that happens, the infection it can spread beyond the tooth root. So one of the main ways these infections spread in through that is known as the pulpal infection. So that happens when the inner part of tooth, that is the pulp, it get infected. So when that happens, the infection it can spread beyond the tooth root. So how fast this infection spread or how serious it can get, it will depend upon the few things. The first is the type and the strength of the microorganisms, how strong these microorganisms or the bacteria are. So some bacteria they are more aggressive and may cause more trouble than the others. Second is how strong your body defense is. Your body has its own defense system to fight off these infection. So if your body resistance or defense system is not strong, the infection it can spread more easily. The third is the shape and the structure of the infected area. So the structures like the surrounding bone, they can play a important role, or if there are certain pathway or spaces, the infection might be able to spread more quickly through these areas. So that will depend. So the first is the bacteria invasion. The first thing, decay happens when the hard outer layer of the tooth known as enamel get damaged by bacteria. That creates a way for bacteria to get inside. So sooner these bacteria they will enter the pulp and they will cause a reaction. So that makes the area inflamed, swollen. That would cause inflammation, edema, and collection, and there would be lack of collateral blood supply. So when the pulp does not have lot of extra, so there would be a lack of blood supply that makes it harder for body to get rid of the infection. So there will be a necrosis that would consist of pulpal death tissue, and there will be a reservoir for the bacteria growth, creating an anaerobic environment. So that can further spread the bacteria into the surrounding alveolar bone. So when the infection it starts in the soft tissue, it can take on different forms. In the acute stage, these forms are typically seen as abscess, cellulitis, or fulminating infection. So abscess, it is like a pocket or infection. Picture a thick wall cavity filled with pus that will be filled with the bacteria, dead cells, and tissue fluids. So these infections are usually caused by bacteria like Staphylococcus, whereas the cellulitis, they are type of infection that spreads within loose connective tissue of body. Picture it as a diffuse or widespread infection that can affect areas like skin, mucous membrane, or the deeper tissue. So cellulitis, remember, it's a acute phase, and abscess, it's a chronic phase. The pain here is so that's the difference between cellulitis and the abscess. So remember, in cellulitis there would be no presence of pus, and in abscess you will see pus. So that is why it would be fluctuant and well circumscribed. So cellulitis, it is an infection that affects the body deeper tissue. So it shows redness, swelling in the skin or mucous membrane. The thirds are the fulminating infections. They are the severe and they happen suddenly. They can spread rapidly and cause serious issues. When antibiotics, they are not doing their job in supporting the infection, and when there is suspicion of pocket of pus that have not responded to treatment, it is important to explore the area and drain these pockets to get rid of infection. Antibiotics can stop the infection and sometimes evenly completely clear it up. There might be collection of pus drainage that becomes essential to remove the infected material. Now, what are the types of the odontogenic abscess? The first is the acute periapical abscess. So this kind of abscess starts and stay within the bone that holds the tooth. So it is also known as periapical abscess. So it is infection that is confined to area around the tip of the tooth root. Second is the acute dentoalveolar abscess. So when the infection breaks down from the alveolar bone and spreads into the nearby soft tissues, it is known as dentoalveolar abscess. Third is the acute periodontal abscess or the acute pericoronal abscess. So pericoronal abscess occurs when around the partially erupted teeth, usually the wisdom teeth, whereas the chronic form can include chronic fistulous tract. When abscess it persists for longer time without proper treatment, they might start draining fluid. So if abscess drain fluid through the skin, it might result in the formation of sinus or fistulous tract. Other is the chronic osteomyelitis or cervicofacial actinomycosis. Now the inflammation, it is a acute biological response to the harmful stimuli such as pathogen, damaged cells or irritant. Now what can be the type of inflammation that you should know? The first is the acute inflammation. So it is the initial response to injury or the infection, and it is characterized by the rapid onset. So it typically lasts for the short duration, that is from minutes to few days, and involves the release of inflammatory mediators like the histamines, bradykinin and prostaglandins. Now what are the cardinal signs of acute inflammation? The first is the rubor, that is means the redness. So increased blood flow, you will see increased blood flow to the affected area causing redness that occurs due to the vasodilation. Second is heat, that is calor. Increased temperature in the area is seen due to increase in the blood flow. Tumor, swelling or edema, accumulation of fluids and inflammatory cells could be seen. Dolor means pain, stimulation of nerve endings due to release of inflammatory mediators that could lead to pain. And last is functiolacia. So loss of function could be seen. So these are the cardinal signs, 5 cardinal signs of inflammation. They are rubor, calor, dolor, tumor and loss of function. Other is the subacute inflammation. So this phase acts as a transition between the acute and the chronic inflammation. So it persists for a longer duration as compared to the acute inflammation, but it typically presents with the milder symptoms. The third is the chronic inflammation. So this phase includes a prolonged response that is from weeks to years, with fewer classical signs of inflammation. Instead, it is characterized by, you will see, infiltration of immune cells like the lymphocytes and macrophages. So there would be development of the connective tissue. Chronic inflammation can arise due to the persistent infection and prolonged exposure to irritants. Now let us discuss what are the phases of the inflammation. The phases of inflammation, that could be the number 1, the serous phase, that is the initial phase that lasts for around 36 hours. It is characterized by increased vascular permeability that leads to leakage of fluid and proteins into the affected area. The area would become red, firm and painful due to increased blood flow and accumulation of fluid. The second is the cellular phase. So following the serous phase, there would be influx of the WBCs, especially the neutrophils into the affected area. So there would be accumulation of these cells that would lead to pus formation. If it occurs in a new cavity, it's known as empyema. So if it develops in a cavity that already exists, it is known as the empyema. The third is the reparative phase. This phase involves the tissue repair and regeneration. It will begin almost immediately after the inflammation would start. So in this phase, the damaged tissue, they are removed, and the reparative process it begins. They try to restore the tissue structure and the function. So this table shown represents the acute chronic periapical infection that can cause bacteremia, deep facial space infection, ascending facial, cerebral infection, or you can see osteomyelitis, intraoral soft tissue abscess, fistula, or cellulitis. So next important thing is what is Hilton's method. So Hilton's method, it is a method of incision and drainage. So that ensures a safe way to open an abscess without damaging the nearby blood vessels or the nerves. So what are the steps that are involved in the Hilton's method? First of all, the area, you will numb the area with a spray like ethyl alcohol to minimize the pain during the procedure. A small cut, that is incision, it is made at the point where abscess appears most swollen. So the most fluctuant part, incision is made. So this cut would penetrate the skin and underlying tissue. So if no pus is found initially, sinus forceps, they are used to gently probe the area to avoid harming the important structures. So the closed forceps, they are guided carefully through the deep tissue to reach the collection of the pus. So once reached the forceps, they are opened in direction away from the vital structures. So the cavity, it is explored for additional pockets to ensure the complete drainage. After that, soft drain made up of latex or rubber, it is inserted into the abscess cavity. The drain, it is left in place for around at least 24 hours. That would allow the continuous drainage and irrigation of the abscess cavity. Now the purpose of drain, it will allow the discharge of the tissue fluids and pus from the wound, keeping it open and clean. The drain, it aids in the cleaning the abscess cavity by allowing irrigation. So when the discharge has almost stopped completely, drains, they can be removed. Leaving drains too long can introduce skin bacteria into the wound. So this is Hilton method of incision and drainage. Now you should know the spread of oral infection. It can occur through the various routes. What are those routes? The first is the direct continuity through the tissues. So that can the infection, it can spread locally through direct contact tissue points. For example, a dental abscess, it can extend from tooth into the surrounding bone or the soft tissue, or the lymphatic spread. Infection in the oral and facial region, they can progress through the lymphatic system, reaching the regional lymph nodes, and there they can cause secondary abscess. The third is the hematogenous spread, that is through the blood route. So local thrombolysis, inflammation of veins with the blood clots, can occur, particularly in the facial vein. So this condition can propagate along with the veins and enter the cranial cavity through the missionary veins. That can lead to cavernous sinus thrombolysis.
Now, the lymphatic system, remember, it plays an important role in draining tissue fluids. So, the lymphatic drainage, the number one is the submental. You can see is the submental lymph nodes. The area drained are the tip of tongue, part of floor of mouth, mandibular incisors, the submandibular lymph nodes. These are the submandibular lymph nodes. The submandibular lymph nodes, all the maxillary teeth, mandibular teeth except the incisors, inferior nasal cavity, palate, body of tongue, upper lip, lateral portion of lower lips, areas of the lymph node drainage. Now let us discuss the local factors that would affect the spread of the dental infection. They could be the intact anatomical barriers. What are those barriers? They could be alveolar bone. So the bone, it acts as a first barrier to prevent further spread of the periapical infection. So as the infection it progresses within the bone, it spreads and extends toward the cortical plates. The second is the periosteum. The periosteum, it provides a limited resistance against infection. So it can lead to formation of subperiosteal abscess. Or it can travel into the adjacent muscles, fascia. That could be the next localization site for the infection. Now the periapical area infection, it can lead to focal osteomyelitis if confined to periapical region. Chronic periapical infection may result in bone destruction with well-defined demarcated corticular radiolucency that you will see on the radiograph. There may be formation of fistulous tract. Infections can form fistulous tract through the alveolar bone exiting into the surrounding soft tissues. So the infection from the upper teeth, it may manifest depending upon the location of their root apices. Infection from different maxillary teeth, it may extend buccally, palatally, posteriorly due to their varying the root positions. Spread of infection from the maxillary molar may involve the buccal vestibule, buccal space, and left commonly the palate or the maxillary sinus. Infection of the mandibular teeth, they may present as bulging masses in the labial sulcus and may spread into the submandibular space. The mandibular third molar, it presents with the pericoronitis but may be associated with the root apices leading to various spread pathways like the buccal, masseter, and parapharyngeal space that we would discuss later on. Now let us discuss the spread of infection from individual tooth, especially concerning the upper central incisors and the lateral incisors following the specific pathway. So first of all, the upper central incisors. So this tooth commonly drains into the labial sulcus that causes the swelling or the edema of the upper lip. Infection from the upper central incisor typically do not extend into palate. However, if the incisor it is severely inclined, so if the incisors they are inclined, then the infection it can spread palatally. So this might lead to the abscess formation that is present near the junction of the hard and the soft palate. Sometimes it may spread into the abscess may spread into the floor of nose. That is highly unusual from the upper central incisors infection. The upper lateral incisors, the spread of the infection from the upper lateral incisor, it is comparable to that of central incisors. As root apex of the lateral incisor, it is situated deeper compared to the central incisor. The palatal infection, it is more common. The spread into the nasal cavity from upper lateral incisor, it is even rarer compared to the upper central incisors. The upper canine tooth, it is characterized by long root. So it typically has a long root, and when fully erupted to its apex is typically positioned high in the maxillary bone. So this position may be slightly lateral to the curved junction where the lateral and inferior margin of the anterior bony aperture of the nose meet. So when apical infection occurs in the upper canine infection, it can spread into specific anatomical space that is known as canine space. So this space, it is a subdivision within the superficial facial compartment, and it is situated between the two structures. One is levator labii superioris muscle. So this muscle, it is located in the upper lip, and it is involved in elevating the upper lip. So the bony, the maxillary labial plate of bone, it is the structure that surrounds the root of the maxillary canine. So the infection from the apical area of the upper canine tends to spread into this particular compartment that is known as the canine space. So this space, it is confined between the muscle and underlying bone structure. In case of dental infection, the proximity of infection site to this space allow for the spread of bacteria and inflammatory material into this anatomical compartment. Now the periapical infection from the upper canine usually perforate the buccal alveolar plate to point into the buccal sulcus below the levator anguli oris, and if the perforation, it is above the muscle attachment, it leads to canine space infection. Upper second premolars, the infection from the apex of the second premolar, they are more inclined to spread buccally toward the cheek rather than the palatally. Sometimes the apices of these premolars can be close proximity to the underlying maxillary sinuses. Buccal penetration infection spreading buccally might penetrate the labial plate of the bone, allowing the entry to spread superiorly into the soft tissue of the cheek. The infection, when progress upward and laterally, it may pass underneath the lateral border of the specific muscles such as levator anguli oris and zygomaticus minus major. Now next is the infection from the molars. Infection from the palatal apices of the upper molars tend to track either into the palate or upward into the maxillary sinus. The buccal apices of upper molars, infection from the buccal apices of upper molars typically direct toward the buccal space. Infection may spread either above the region of buccinator muscle, allowing entry into the superficial facial compartment or less commonly into the buccal sulcus. So the attachment of the buccinators superior to apices of maxillary molars, it regulates the spread of periapical infection. If the periapical infection erodes the buccal bone below the attachment of the buccinator muscle, it results in a buccal vestibule abscess, that is this, and if it perforate above the buccinator muscle, then it leads to buccal space infection. Next is the spread of the infection from the upper third molar. Buccally, the infection from the upper third molar, they are more prone to spread posteriorly and superiorly. So the directional spread, it is due to the downward curvature of the posterior part of the region of the buccinator muscle that lies between the tuberosity and upper part of the anterior border of tergomandibular ligament. So from the tuberosity, that is the last, tuberosity is the rounded prominence behind the last molar. So from the tuberosity, the infection can track medially into various spaces. Medially toward the area near the tonsil, that is known as paratonsillar space, along the tendon of tensor velli palatini upward into the hard palate and soft palate. It can go superiorly into the tergopalatine fossa and deep pterygoid space, or posteriorly and inferiorly into the space adjacent to throat, that is parapharyngeal space. So from the tergopalatine fossa, it can further goes to the dangerous sites. Now from the infection originating from the apices of the lower incisors teeth, the position of apices of these teeth, they lies closer to the labial than the lingual cortical plate of the mandible, make it more probable to drain into the labial sulcus. So in case where the infection extend lingually, it may go into the sublingual space. So from sublingual space, it may travel into the submental space. So infection originating from the lower canine, due to longer root structure of the lower canine compared to the incisors, the spread of infection is likely to be deeper than the labial sulcus. It tends to extend into the superficial facial compartment. Internally, the spread may be slightly impeded by the region of the depressor labii inferioris muscle and more superficially depressor anguli oris muscle. So these muscles are attached to mandible at a distal level compared to the depressor labii inferioris muscle. The infection from the buccals, from the lower premolars, from the buccal side, the infection typically enter into the vestibular space. It may then proceed either below or through the buccinator muscle to gain access into the superficial compartment. You can see swelling around the mental nerve emerging from the foramen below or between the premolars that can lead to altered sensation in the skin. There may be lingual extension that may typically involve the floor of mouth. Initially, the infection can enter into the sublingual space. It may then perforate through the mylohyoid muscle to access the submandibular space. Infection from the lower first and second molars, they are typically symmetrical position. The first molar, they are typically symmetrical position in the mandible with equal thickness on the buccal and the lingual bone covering their roots. The second molar, they are situated more lingually toward the tongue and they have a thicker buccal bone. So infection from the first molar, it is more likely to track buccally. So it can pass either above the level or below the level of the buccinator muscle. Depending upon the perforation point, it may enter either the vestibule or superficial spaces. So infection from the from lower second molar may likely to involve the submandibular space. Infection from the third molar, they can track into paratonsillar, parapharyngeal, superficial pterygoid space. Infection may extend into these spaces, potentially leading to complication. Lateral to the distal part of the paratonsillar space are the carotid arteries, internal jugular vein. Pus in this space, it is close to major vessels of the head and neck. So the lower third molar location, it is critical, and infection spreading posteriorly might extend into various important spaces in